when I asked the first question to introduce yourself, a little bit about kind of where you're working, the attributes of where you're working, and then we're going to get right into it. Okay, all four of you have mics, right? Wonderful. And then I want to make sure we leave a little bit of time for questions because, I mean, listen, these people have a lot of really important things to say. So we're going to go ahead and first get started and think about sort of data frameworks, right? All of you, as mentioned, are sitting on all different kinds of data: clinical data, financial data, operational data. What are some of the frameworks that you're thinking about and have used successfully? And what are some of the architectural decisions that you've made? So for this question, we'll just kind of go down the line and then we'll pull out some insight.
Hello, I'm Mark Weiner. I'm a general internist and informaticist at Weill Cornell right here in New York City. So Weill Cornell is a large academic medical center in the Upper East Side. We are the academic affiliate, or one of the two academic affiliates of New York Presbyterian, which is an interesting arrangement where one health system is usually with one medical school, but in this case, NYP is affiliated with both Cornell and Columbia. And I see patients a half day a week, and then I also do research in population health sciences, managing this entity called Insight, which is a clinical research network, mostly centered in New York City, integrating data from about 20 million patients across the 5 major academic medical centers in New York City, but also now Houston and Stony Brook out on Long Island.
Awesome. Mark, what are some of the sort of frameworks that you're using as you're thinking about these 20 million patients?
Yeah, so I have the luxury of being able to work with data in a research setting. So I'm able to take the data out of whatever source systems it's in, which is mostly our EHR, but then we can integrate that data with claims data. Then we also integrate it with outside claims data, Medicare, Medicaid, commercial insurers, and then other data on the environments where we're able to link information on at the census tract level, so we know the environmental exposures that people have, and we can link that to their healthcare.
Great, thank you. Divya.
Everyone. My name is Divya Pathak. I'm the Chief Data and AI Officer for the New York City Health and the largest municipal city system in the country. We serve over 1.4 million New Yorkers, irrespective of their social, legal, and economic backgrounds. So you can talk about data. We're serving the most heterogeneous data population in New York City. And when we talk about frameworks, I think currently, as we are a health system, we do integrate our payer information with our provider, in addition to all the SDOH data that we collect externally. And we have gone with a very modernized data fabric architecture in support of integration. We also work with the DOH, MH, and other city agencies. So there is a high need for semantic interoperability of these data sources. And we've tried our best to keep it open source. So we're basing it on HL7 and FHIR for interoperability. And internally, we're trying to build a persistence layer, which is based on FHIR and also based on OAuth, just so that we're able to have open data sharing with other entities.
Thanks so much, Divya. Pam.
Yes, hi, I'm Pam Secha. I'm the CEO of Elite Groups, and I would say from a organizational standpoint, we work with a lot of safety net organizations. And when I think about data framework, obviously, we work with various ecosystems, different EMR systems, different data platforms. But at the end of the day, I think some of the most successful data frameworks that we work with in a lot of organizations is specifically around incentive-based programs that really drive clinical, financial data, aligning the operational workflows, and really driving what I would consider patient outcomes with ROI to generate incentive programs that generate, revenue. Like for a safety net organization, one client we're working with is they depend on the $260 million a year. And so to do that, you have to bridge and broker all the different data sets that you use into a data warehouse where we could actually slice and dice the data and actually know real time how to drive those outcomes, and know specifically by year end when you're submitting, where will you be able to achieve in terms of those incentive programs given your performance. And so that's a lot of the framework we use is really working around how do you align clinical financial data to the operational workflows, and how do you have a feedback loop to come back and drive those operational practices where care gaps are getting missed, and how are you working on that? So it's very data driven and action oriented.
Pam, you're speaking my nerdy chief quality officer love language right now, right? As we think about sort of value-based programs. Kendall, tell us about your work environment and how you're approaching data.
Set the stage on clinical pharmacy, doing clinical trials that may not be top of mind for those in the room, and specifically those who are data geeks. But what Walgreens sits on is 131 million lives. 9 million people go into a Walgreens every day. So the access to patients is something that, for our business model, for our sponsor organizations, we have proximity and access to the patients that studies that our pharma partners are looking for. In the use of a cohort browser, we take our pharmacy records, and we can, within a 30-minute period, identify patients against inclusion/exclusion criteria in a sponsored protocol. So that efficiency allows us to then give a proposal on the different elements that we needed. We append geodemographic or socio data, all the SEO data. We have a number of technology partners that we can append, for example, medical records. 90% of the country, we append to our Walgreens pharmacy record. And so by having that holistic of a patient's life, we can identify where there may be barriers to participate in the trial. We know that underrepresented not get invited to participate in a trial, and so by having access to that SBA, we know that there are other facilitators that we're going to have to implement at the program levels and either that patient or address their centralized clinical trial by variety of things.
Oh, we're going to work on the mic. So 130 plus million lives, right? I saw a lot of people nodding, right? When Kendall, you said that.
If you heard that, right?
That's right. If you heard that.
We heard it.
Well, so you know, it's really important as we're thinking about all the data elements that you're describing, governance, right? And in talking with folks across really the world, in our country as well, sometimes people skip a step, right, and then have to backtrack, right, as it relates to governance. And so I'm gonna start with Kendall and then go to Divya, Mark, and then to you, Pam, kind of from your bird's eye view. I'm curious about, you know, how you have, what have been some of your successful approaches, or what are some tips related to governance, especially when you're thinking about that much data? Kendall.
Yeah, well, I'd like to start with, there are more meetings than any organization has meetings. I would say we have meetings a couple of times a week, couple of types of meetings every day. And some of them are with legal privacy and compliance. We get opportunities presented to us all the time, and no one sponsor has the same challenges. I mean, a similar study in one therapeutic area is not going to be a cookie cutter for another therapeutic area. So us being able to meet with and have our protocols reviewed in that setting allows us the kind of feedback that we would need in the provision of a recommendation for here's sponsor, here's our proposal for how we would either recruit a clinical trial, how we would conduct a real world evidence study. And so it has the correct guidance and guardrails.
Excellent. So what I'm hearing is, regardless of type of partner, whether it's a clinical setting, whether it's a different kind of vendor, it's those early conversations that really help shape
And
things.
consistent conversations.
Thanks for that. Divya, what about you? You know, as a health system, as you said, very, very diverse, needing to work with all different kinds of people. How are you thinking about governance, especially as it relates to the sort of other inputs? Ooh.
So I'm going to take a very different. There is a.
The Zoom is giving us feedback. Okay, we should be good now. Thanks, Megan.
Thank you. So Komal, I'm going to take a very different approach
Okay.
when it comes to governance and health systems with respect to use of data. when we talk about governance, again, meetings, but more than meetings and in having the multidisciplinary teams in a health system that includes your legal, that includes your compliance, that includes your clinical and your business stakeholders. What is more important is to have a very established process of embedding governance in the entirety of that data lifecycle. And what do I mean by that? All the way from acquiring the data or acquisition of data to actual use of data to standardizing the data for consumption to support your downstream analytics, downstream insights, and downstream AI efforts. I think oftentimes governance is uh, more of a process that people just say, yeah, we've got to do governance and we've got to have all these groups together. But what actually is an artifact that's produced, that's embedded as part of your end-to-end use of that data is key. Example, we make sure, and you are part of it too, is in New York City Health and Hospitals, when we talk about any consistent use of data, we work with our business stewards, including the chief quality officers, to understand the clinical context of the data that's being used. So the clinical context, having that business level understanding of the data use, having consistent definitions, reconciliating all the sources to make sure the definitions are and the logic used to use that data is the same is important. And how do we do that, right? We want to make sure that anytime there is use of data, we are actually able to catalog those definitions. It's a cohort of definitions that people can look at, discover, so that they're able to use it. So governance is more of a embedded process in support of that entirety of that data lifecycle.
I love that. It is process, it is culture, right? It's so much
It's a
more
culture.
than
It's
what's
very,
written
very
on
cultural.
paper. Thank you for that, Divya. What about you, Mark? How are you approaching governance?
Sure. Well, in addition to what the other speakers had said, what I like to focus on is for many people, governance is HIPAA, patient privacy, and obviously that is very important. But the other issue is healthcare data as intellectual property, and you have to respect that as well, because the data we have within our clinical research network is all de-identified. And so, but it's not enough to say, well, we're adhering to the principles of HIPAA. But what we have to do, because we merge data from across several health systems, is we have to be mindful of the concerns that the participating health system has regarding the use of the data. And there's no simple use. If we want to do a study of diabetes that really spans all of New York, we have to be sensitive to the fact that if we're not careful, an investigator, an academic, not even a business or quality person, might be able to conclude that one health system is better than another. And we have to work very hard to enable the research and the high, the improved quality of care that comes from that without embarrassing, any given health system. And the worst case scenario is if a paper gets published that a health system was unaware of, and it may put them in a bad light or something like that. Or, even if you go hospital A, B, C, D, if there's some way that someone might deduce which real hospital is hospital A, and that can be done because the hospitals are in different sizes, and Monty has a concentration of people from the Bronx and zip codes, whereas we all have all the health systems have patients from the Bronx, but Monty had. So a lot of the governance, we like to have policies and rules and discuss everything in advance, but a lot of it is just a philosophy and just a certain degree of trust, which had to be earned over the several years. So it's a combination of many things.
So, Mark, do you have a process where if an investigator wants to publish something, or is it all on the front end where they're submitting research protocols and sort of you ensure trustworthiness that way?
We wrestle with this, and again, we have policies which talk about levels of escalation, with different people having to be involved. But sometimes the committee, and I chair this research prioritization and review committee, we frequently will escalate to governance because even though we set policy and this looks right, the actual research is different enough where the policy doesn't quite fit. And then how do we allow that to proceed without having to, redo the whole data use agreement process, and keep it sensible and pragmatic. It's hard sometimes.
Yeah, definitely an emerging area, right? As these things get more complex. So, Pam, I'm going to turn to you in a minute, but I'm just going to seed the next conversation for the rest of the panelists as well. I'm going to ask you, what is one team member or type of team member that you had to add to your team that you didn't sort of have in your initial sort of go around, and sort of what were the learnings around that? And what is one data source or data type that you don't currently integrate that you would love to integrate? So I'm just going to let you mull on that for a minute. So, Pam, as with your vantage point of dipping in and out of sort of different types of settings, you've heard a lot about, sort of best practices related to governance. What's going through your mind, and what would you like to add?
Yeah, I'd probably bring a slightly different lens, I think, to play, being on the IT side as former healthcare IT executive. A lot of our roles is helping to implement or put in technology to support the business and the clinical side of the house, right? And so as a result, a lot of time I'm in a position with our IT team to be in a support serving role. And so our role is to facilitate, I always call, we're more of an air traffic controller, and so setting up a data governance group has always been a very important aspect in our job duty, I would say, in order to make that effective. And so identifying your stakeholders, right, across your clinical, business, compliance, privacy, security officer, and being at the table with you, with your CMO, chief quality officer, those are things that we do. And how do you provide a nimble yet agile team and lean enough to represent the system, especially when you're in the largest public health system, right? As an example, because I actually was at New York City Health and Hospital, put in the first EMR at Queens and Elmhurst. And so I understand in doing something like that, when you go live with Epic, which was a major part of your life at the time, it's like you think that is the end all be all. And you get so much data and rich data, like, what do you do with it? And so a lot of times shaping the data governance team for us is like, I always say, start with the end in mind. Like, what is the outcome you need to achieve from a business or clinical perspective? Based on that, you kind of work backwards and you kind of say, where's the source of data being entered? Who's actually putting in that data? Because you have to map out the workflow and align to the workflow. From the workflow, then where is the data being triggered to capture that information? And being able to capture that information, then you go, if something is wrong with the data, right? Where is the root cause? Is it a workflow issue? Is it a data accuracy issue somebody put in? Because on the IT side, a lot of times it's like, we don't like the data, so you must be telling the wrong story. And that's no disrespect to anybody. It's like, okay, I'm not telling the story, right? This is the output of the report. And so let's talk about this a little bit. Who's responsible for putting this? You start tracing back the workflow and you're like, I need to go back to Dr. X because this wasn't entered. Who's educating that physician? Or the MA put that in. That's probably not where it is. Oh, we weren't told this was a requirement we have to build in the system. Therefore, we weren't capturing that data. So let me go backwards and capture the data. So to me, setting up the data governance structures about having the right stakeholders at the table and then we do create like work groups specifically around incentive programs, access issues that come in. They review the policy, make sure people get access, so you stage up the different subgroups underneath that, I would say. But at the end of the day, I think when I think about data governance, it's really ensuring we have good data stewards throughout the organization who can champion the data, can speak to the data, and we have common data definitions. It's really interesting. I don't know how many of you can raise your hand, say it's surprising that you can get a clinical person in the room and a revenue cycle person in the room, and your length of stay definition is so different. And you're like, how is that possible? CEO, how do you interpret this at the end of the day? Like, who defines that and shapes it, right? So that data definition is so critical to get alignment. So to me, when I look at data governance, we're facilitating the process of getting to the common understanding, getting that alignment across the board. And so that's the criticality of, data governance for us. Right people, right place, right data, and let's be on the same page on how we're using this data. And before you say the data is wrong or it's telling the wrong story, let's make sure we believe the right people are putting the data in and we're following the right workflows.
Thanks for that, Pam. It all comes down to the humans,
Mhm.
right? Our most challenging and amazing resource right at the same time. So we're gonna get to that juicy, like what gets the C-suite all hot and bothered in a minute. But I did seed a question. So Ken, I'm gonna start with you and go down the line.
Yeah.
What was one sort of type of team member that you had to add to your team because you learned something? And what is one data source or one type of data that you don't currently integrate that you would love to?
So picking really up where Pam left off, one of the things that we realized when we first started the business in June of 2022, okay, you think a pharmacy record, you know what prescriptions a person is taking, so you can see that in full scope. But it doesn't have SDOH data. It doesn't have a medical diagnosis. What prescription you take is not in the same data source as the data that holds what a person's diagnosed. So physicians can treat off-label and often do. So just because you see a prescription in a pharmacy record doesn't mean a person is being treated for the one indication that you might assume. So don't make assumptions. So what we ended up needing, there were heads when we first started the business. There's me, head of digital optimization. There's a head of real world evidence. There's a head of decentralized clinical trials or the virtual at-home model of clinical research, and a head of study conduct. What we didn't have was someone who was a data science person. We didn't have a team of data scientists. We also didn't have a team of epidemiologists. So those functions were added into the real world evidence pillar of our business model in order to start to pull in other data sources and people who knew how to interrogate the data source, be able to append those data sources onto the pharmacy record, be able to quickly develop a cohort that was inclusive of claims data, of the EMR data in our partnership in that context, and then to be able to answer sponsor questions or come back to a sponsor with a question they hadn't contemplated, because now that we have those sources all in one place, that's not something that we started off with just the pharmacy record.
Awesome. And so
Brought in
I love
data
that.
science and
Data
epidemiology.
scientist. Wonderful. Pam, what about you? A type of person that you often have to bring in that doesn't already exist, and a type of data source that people want to get behind.
I'm gonna build upon Kendall.
Listen, y'all are friends, right?
I swear I did not talk to her before this panel, but I'm gonna build on her comment, because for those who go live with Epic in this room, or even Cerner or Meditech for that instance, a lot of people always think they have this myth that when you go live with a platform like that, it's the end all be all solution, right? And so one of the safety net organization I work with, again, I mentioned earlier in the start, they're very heavy in incentive programs, value-based program. It's a big part of their revenue. It's about 40% of their revenue in the organization. So their thought process, we don't really need that many BI developers. And when I say the word BI developers in this context, they're actually data scientists with technical background. And so they're like, we don't really need that group. I happen to have walked in and be one of the leaders that oversaw the chief digital space for data analytics, and it was gone. They've been repurposed to do clarity report writing and Epic benchmark, workbench. And so when we went down to it and we started producing the data to go to the incentive program, we realized that data is not available. I mean, this is about 7 years ago for those of you in those moments. HEDIS wasn't even mature in Epic to be able to produce some of that data. And so we had to spin up our own database in a SQL server. We had to create our own BI analytics developers, and they were data scientists. And what we did is we used to have, by the way, when they disbanded that, they all kind of went back to some of the operational units. So I had to bring those operational units back. And we went to each of those operational areas and said, I need a data scientist from your area in billing that knows claims very well. I need someone in pharmacy who knows medication well. And we created that team and spun them up within a 90-day cycle in order for us to create the 40 plus QIP measures that were necessary by the year end to hit our first target of the $200+ million by the end of like a 5-year program. And we're at risk for not achieving it. And so for me, I think that's the one, I would say, myth we think about. Like, it could be a one end all be all solution, but BI developers with data scientist mindset was really important for us. And obviously visualization, right? Power BI, Tableau, way to visualize things, because outputs don't really tell you story unless you get a good visualization, because pure raw data does not allow you to tell the story. So facts tell, stories sell. So how do you build the visualization to sell the story. And so then you got to like bring in those powerhouse layers to it, and you lay on top of that framework to tell the story, which are visualization people.
I love that. Thank
Yeah.
you so much. Divya, what about you?
So a couple of things related to last two questions, right? Related to the source.
And source.
I think source, given that we are a city entity, that we deal with a lot of value-based population. So
Disrupt for you guys.
Sorry?
Disrupt.
that's right.
200
that's
million.
right, exactly. So in being able to actually do value-based analytics, we did need the payer membership data from all our payers. So today it's not, set up in a way that there is bidirectional exchange of this data, even among some of our own payers, which is Health First and Metro Plus. So that is one of the data hub infrastructure that we're trying to establish now, is to make sure we have the payer membership information. So we're actually taking care of the well-being of our population, given that health and hospitals is not just a medical care institution, but it also supports all the social determinants of health needs when it comes to housing, when it comes to food and other transportation and other areas. So that's the source. In addition to it, I would also speak about different modalities of data that we do not integrate well. We have our PAC systems with affiliates, including NYU Langone, Mount Sinai, and others. We do have a radiology imaging data that's completely in a very different setup on-prem compared to our other data that we have actually adopted the cloud. So in terms of integrating, I think integrating the imaging modality in our entire data platform would be an important resource. Talking about skills, several. So any traditional health systems always treats data as with a project, right? I need a report, I need a document, I need extracts. I just need just enough data so I could do my research analysis and dashboards, whether it's within Epic and others. But so the end of that data request ends with, okay, we start on an effort and then we end that, and the data is shared with them, and that's it. So we enter into a problem of plenty where we don't treat data as a product. And given my experience outside health systems, I look at data as more of a product than as an asset with a project mindset. So being able to bring that product thinking is a big cultural shift in our institution, and able to hire data product managers, technical product managers who are really looking at data in that life cycle, being able to actually support not just delivering the data, but also maintaining the health of that data throughout that, because data changes, practice changes. There's so many reasons why there is shift in the data that's being delivered. So that's number one, product thinking. So having technical product data product managers. The second is implementation scientists, along the lines of data scientists, but more related to translation of analytics and insights and machine learning now recently. There's ample work that's done to publish machine learning models, but there's very few that you can call as success stories when it comes to translating them into clinical workflows. So that's implementation science. There's a lot of science involved in actually taking something, even if it's an Epic generative AI feature or a predictive model, there is still a lot of clinical validation and protocols required in support of the equity analysis, given the patient population we serve, in support of the clinical effectiveness and the clinical assessment of how good is that model. That's a skill that I would say, right? That's implementation scientists in addition to the data science skills that's needed.
Workflow.
Awesome. Thank you. I see like everyone's head nodding. That's awesome. Mark, what would you like to add to this?
No, and thank you for being last on this one. Yeah, 'cause I've changed my mind several times. So, the first thing I was going to say, it's not a skill set we actually have at Cornell, but among our network at Mount Sinai, there's a woman there, Crispin Goitier, who does patient engagement like nobody's business. And basically, whenever you are doing an analysis or more formal research study of, you name it, you want to be able to call together a set of people with that disease, and she is a master of that, and it's very helpful on a number of levels. But then, as Thea was saying, I realized, we are masters of the structured data. And we have some skills in the unstructured data, but what we really need, where we really need to knock it out of the park, and I think the wave of data analytics is the imaging data and the narrative data from radiology and pathology and, anything that has, narrative result, clinical notes, radiology reports, sleep study results, you name it. So that sort of counts as a data and a kind of expertise that we lack. And then I can go on and indefinitely about, just data I would like to have, but it's in general, anything that gets me closer to what I'll hand wave and call the truth. Because we only know the data that we capture when the patients are in our environment. And, so there's a lot of mobile health technologies and wearables that, aren't necessarily in common use, but could help fill in those gaps of how well a patient is doing after they leave the clinic and after you, implement the treatment. So I'll stop there.
I love that. And so many wonderful pearls here. And my call to action is unstructured data, even within the structure, even in the things that we are looking at, there's so much that we can do. Megan, I just want to do a time check. I know we were a little late to start. When is our end time? 10 minutes. Oh, excellent. All right, then I'm going to ask my last question before we go to audience questions. So we talked about the C-suite getting all hot and bothered, right? And yet at the same time, as many of you have said, like data isn't necessarily always like the sexiest thing. There's many, many competing priorities. Can you give the audience a nugget about how do you really sort of impress the importance of the ROI of data and data governance, right? Thinking holistically about data and data governance. And so, Mark, I'm going to start with you and then go down the line. And let's keep our answers brief so we have time for audience questions.
Okay. Yeah, I mean, again, from the research perspective, data is the currency that really drives research. And until recently, research was a lucrative venture. So it's a harder argument to make in the present day. But still, for operational purposes, and I think my colleagues here will be able to speak more to this issue, but I have in my past, worked with data around quality improvement, or around process improvement, reducing wasteful spending. Without the solid underlying data, you could, read a research article of something that worked at another institution, and you say, oh, well, let's just implement it here, and it'll, we'll save the same amount of money. And I've seen many examples that if you kind of leap before you look, just assume that, what worked at another institution will work at your place, you may end up wasting more money. And good use of data allows you to model an expected outcome at your institution, given your local issues. And I think that's very valuable.
Love that customization to local practice. Divya.
So I always look at any data and analytics, IT, digital efforts in health system. I'm going to take a health systems perspective. Even in academic medical centers, these organizations are always a cost to the enterprise. Now, when you talk about what gets C-suite excited is not always the foundational efforts, the cleansing of the data, the standardizing and making this data available, having good governance. All this is only so good as long as it meets a high impactful strategic need for the organization. So when we talk about projects, this is what I do, is we talk about those high impact, high ROI, strategic requirements as an institution. Aligning those with the efforts is key. And being able to pick those use cases to drive end to end, that includes the foundational efforts, but having the business value delivered at the end of it is important. So that shows the value add, because there is an indirect attribution of data and analytics organizations to clinical, business, finance, and other stakeholders. So it's important to show that end delivery use case that can get your C-suite excited, number one. The second is making sure you are actually looking at financial use cases. A great example is How do we increase the revenue potential? How do you reduce the denial rates in a health system? How do we lead to cost savings? So we're able to actually improve the productivity and efficiency of the work. So these are all ideal use cases to start with. So we're actually able to offset some of those soft ROI use cases that requires data.
Thanks, Divya. Pam.
Yeah, I think I'm going to go back to my tag, which is facts tell and stories sell. So it has to resonate with, I think, the pillars of the organization. And when you have a well-structured data governance committee backed up by your ELT steering committee level, you're very lucky. And I think I used to tell the BI director, you have the best job in the world because your budget never gets challenged. Part of that is because when he tells the story, it literally like, this is how much operational reports we produce, and this is what it yields for the pharmacy department, the lab operations, because all of those chairs are, they're like, yep, they do that value for us. And then when I talk about incentive programs, our 9 BI developers bring in $260 million, and this is where they all get allocated, like, oh my God, a 40% of our revenue, no brainer. And then here's the stories, like COVID is a good example. We all face that, right? How quickly you need to stand up data that you have to publish to the registries or to talk about, all of the metrics we have to report out. You have that at your tips. So I think it's quantifiable, it's qualified, and you can have the facts, and you actually can tell a very compelling story. And I'll end with a nugget. One of the stakeholders we worked with at an organization, the CIO and I was in an advisory role, and he literally loved meeting with us every time before the board meeting because he loved to prep the storyboard and talk through it so he can share these amazing stories of patient stories and outcomes that they're able to achieve and how it ties to the RFI and the benefits to the patients, to the community, and the healthcare system. And so he's like, Pam, I can sell data all day long as long as you keep helping me tell these stories, because they're real stories to be shared and not everybody knows it. It's like the hidden gem. So I think when you can find how to use that to tell the stories that resonate with your audience, it's an easy sell for the C-suite. So
Love that. Stories, culture, process, feelings, right? So many things.
heart and mind, right?
That's right.
I,
Kendall.
I love this because we didn't talk before the panel discussion, but it's completely relevant to what I was thinking to say, and I will share. So just recently, one of the challenges of clinical research, or at least industry supported drug development, is that everyone in industry trained, everyone is in industry knows the regulations and standards, but what we don't have access to is patients in the room advising on how that protocol should be written so that the data output from a clinical trial is relevant to a patient. If it's not relevant to a patient, the patient won't be adherent to that therapy. So one of the ways that the currency is patients and patient data. And so we just launched a patient advisory board because if we don't have a way to push back on or give feedback into from protocol design, from implementation, okay, you think in your boardroom that it's going to go a certain way based on what you've read in the textbooks or what worked before, but you don't know if you don't have the lived experience of someone walking a mile in the person's shoes with the diagnosis. There are so many things that are left off and are not learned until maybe the product gets to the market. And by then the clock is ticking and it's too late to pivot and then start another trial when the life cycle is coming toward its conclusion. So say all this to say that the currency from lived experiences from actual patients is what we're putting now into the proposals and designing, whether it's community engagement, and the science of community engagement, so that we don't assume that we know what works for patients. Patients inform us, and we've done direct surveys with thousands of people, representative sample of people in the country, 87% of whom said they have never had a conversation about clinical trials with a healthcare professional. If that's the case, and we don't know in industry that we have never had these conversations, how would we expect people to participate and be successful and complete a study if they haven't had a first conversation? If they haven't had a first conversation, we have to go upstream. We have to bring those patient insights in at the beginning of a study's design and development, and then work with patients throughout that life cycle of those studies. So it's an exciting time.
Yeah, thank you for that, Kendall. Listen, so many beautiful pearls were shared today. And I know that I promised time for the questions, but sometimes you just got to go with the pearls. And what a wonderful thing to end on, right? So I will say this, right? I think you know, this idea of patients at the heart, right? And how can we incorporate patients into everything? I'd charge everyone to do that. And so, you know, I'm going to wrap up and I'm going to ask that if you have questions, the panelists will be here afterwards. But with that said, please join me in giving these wonderful individuals a